begin Session 6, which will review patient information, both HIPAA and state privacy rules, as well as the use of the patient information. By the end of Session 6, the technician should be able to describe when a drug utilization review process needs to be done and the resolution of issues with the review. The technician should be able to comprehensively discuss patient information according to HIPAA and state laws and regulations, including how the information will be used and disclosed. And lastly, the pharmacy technician should be able to explain laws pertaining to the treatment of a minor and other special situations regarding consent and protected health information. In general, pharmacists have 6 major responsibilities regarding patient information, both under state and federal laws and regulations. These responsibilities will set the stage for this session. The responsibilities include that the pharmacist must maintain patient records for every patient, which will aid the pharmacist in documenting the distribution of drugs and devices to patients, and in providing pharmaceutical care services to their patients. They must use these records to review therapy prior to dispensing. This is known as a prospective drug use review. They must act to correct any problems that are discovered as a result of this review. The pharmacist must provide information to their patients necessary to ensure appropriate use of their medications and promote the attainment of desired therapeutic outcomes. Oftentimes, this is done through patient counseling and the written patient information that is given to a patient. They must assure the confidentiality of protected health information, or PHI, under their control. And lastly, the pharmacist must use the information concerning patient outcomes and adverse events to continuously improve the quality of their patient care. While these responsibilities are listed as important for pharmacists, clearly technicians being the main support for pharmacists within the pharmacy setting is a key portion of supporting this work and helping to facilitate this care. Technicians oftentimes provide pharmacists with little bits of detail and also are involved in the maintenance of the patient records. The law requirement to maintain a record of all prescriptions dispensed has been in Washington law since at least 1939. However, maintenance of individual prescription records for a patient was not a standard of practice nationally until well into the 1980s. We started seeing some states have requirements for the pharmacist to maintain patient profiles starting in the early 1970s, and it was around that time that the then Washington State Pharmacy Board adopted a regulation requiring the pharmacist to maintain such records, as would enable him or her to attempt to detect drug-drug interactions, multiple prescribing of similar drug classes by different physicians, and the like. The board adopted more specific regulations setting forth the requirements of patient record systems in 1984. Among the changes in practice needed to bring about patient record systems included the following, which were reflected in the 1984 regulations. One was allowing refill information to be reported on the patient profile rather than on the back of a hard copy of the prescription. Prior to computerization, it included allowing the pharmacist to refill prescriptions without going back to the original prescription each time, if the patient record contained a correct copy of the original. Also, recognition that a system of records could be used to meet the needs for patient information, as well as records of the distribution of drugs. This was an important third factor in allowing for the evolution of patient records within Washington State. The Washington regulations now require that every pharmacy and other place where dispensing of drugs takes place to maintain a patient medical records system. This system must assure the pharmacist the means to retrieve all new and refill prescription information relevant to all the patients of the pharmacy. The purpose of the system is to ensure that the information it contains will be reviewed by the pharmacist in a manner consistent with the sound professional practice when each prescription is filled. The regulation does not explicitly require that an individual record is maintained for each patient. However, it does mention that the patient record needs to be kept confidential and seems to disqualify the possibility of a family medication record, which we had seen as the standard in some areas prior to that. The regulation does set forth minimum information that must be maintained in the patient medication record. It specifies this slightly differently depending on whether the system is a manual or computer system used for ambulatory patients. The requirements are also the same for institutional patients, whether a manual or automated system is used, and are repeated for each section. OBRA 90, the federal law around patient information, also requires outpatient pharmacies to maintain the patient's age or date of birth, the patient's gender, and the phone number in the medication record systems. Some believe that the Washington regulation does not require gender as a chronic condition. Does require that gender is a chronic condition that may relate to drug utilization and therefore is also required by Washington state law. In any case, recording the age and gender can be considered a standard of practice, or at least practically necessary in an age of third-party payers, and hence the OBRA 90 regulations. OBRA 90 also requires the pharmacist's comments on comments relevant to individuals' therapies. So if the pharmacist has documentation regarding conversations with the prescriber or their clinical judgments, they ought to document that in the patient's record. This OBRA 90, or Omnibus Budget Reconciliation Act of 1990, set forth federal standards for patient record requirements. We won't review all of these requirements, but states had to modify their laws to match the OBRA 90 requirements in general, so you will see it referred to on occasion. It is the pharmacist's responsibility to screen the patient's profile when checking every prescription. This is considered a prospective DUR, or drug utilization review. So besides checking a prescription to make sure that all the information is on the label and according to the prescription from the doctor, the pharmacist will perform a drug review by using screening tools in the computer system and a review of the patient's profile using their clinical judgment. This includes looking at a patient's medications for therapeutic duplication with the new medication, drug disease contraindications, drug-drug interactions, including any over-the-counter drugs that the pharmacist may know about or ask the patient about, incorrect dosage or duration of treatment, drug allergies, drug abuse risk or misuse. This is all done before the filling is finalized and the medication is handed out to the patient. The computer system is often set up to notify the pharmacist or pharmacy staff of these issues as the prescription is typed. Pharmacy technicians often are the ones who type the prescriptions and therefore may be the first line of seeing these warnings pop up. The pharmacist should be the ones to override these warnings despite the challenges to workflow. Computer systems ought to be able to be adapted to allow the pharmacist the ability to see these warnings without interfering with the technician's workflow. This is an ideal system if at all possible. Workflows may need to be reevaluated to support the pharmacist's review of these warnings if the system cannot accommodate for this. This also explains sometimes why the pharmacists seem to take a while in checking prescriptions, and it's really this fundamental responsibility that the pharmacist has, and the technician has a vital role in supporting this work. We began to discuss the requirements to have patient's history on a previous slide. A complete patient's history is an important part of the drug use review. The history should include name, address, phone number, age or birthday, gender, disease states, known allergies or prior drug reactions, a list of drugs and devices used by the patient, and any remarks on prior drug therapy. Technicians are often integral in inserting this information into the patient's profile and the maintenance of the information, and so it's critical that the technician understand what all should be in this history. The pharmacist will review the drug profile and make appropriate changes if necessary to help the patients avoid any drug complications and maximize their health outcomes. If a prescription from a physician or other prescriber has allergy information or disease state information, it is a best practice to add this to the patient profile with the pharmacist's consent. Washington pharmacy regulations have required prospective drug reviews since at least 1984. The WAC 246-875-040 sets forth the minimum procedures for utilization of a patient medication record system. It includes that on the receipt of a prescription or drug order, a dispenser must examine the patient's medication record visually or via an automated data processing system to determine the possibility of either a clinically significant drug interaction, drug reaction, therapeutic duplication, or an improper utilization of the drug. Also, the dispenser must consult the prescriber if needed, and orders can be modified in the system. But if the order is modified, it must carry an audit trail to show who changed the order, and also any change in drug name, dose, route, dosage form, or directions which occurs after the initial dose has been given must result in a new order entered into the system and the old order discontinued. For example, if a dosage change is made to a prescription, lisinopril 5 milligrams is increased to lisinopril 10 milligrams, that 5 milligram prescription must be discontinued and a whole new prescription for the increased lisinopril 10 milligrams should be entered newly into the system, and also accurately document the changes in the system in a manner such that the original record has that audit trail and is not destroyed. So the previous prescription should be maintained within the pharmacy's system. The Washington rule does not distinguish between new and refill requests. Although it requires the review on receipt of an order, which might imply only when an order is first received, it also requires that a drug utilization review must consider improper utilization of the drug, which involves looking at the patient history of use as revealed prior to dispensing of the drug. Thus, one should consider the receipt of an order to include the patient's request for a refill of that order. So drug utilization reviews, in summary, and a review for problems with the prescription really should occur upon every dispensing of every prescription, refill or brand new, to ensure the safe use and good health outcomes for a patient. Washington state law requires the dispenser to examine the medication record each time, as we just discussed, for new and refill requests of an order or prescription is processed. This involves interpretation of the data in a patient medication record system, which is a professional responsibility that cannot be delegated to ancillary personnel, such as a pharmacy technician. This is part of the verification term defined in Washington state law, and verification means that the pharmacist has examined the patient's drug profile. It requires evaluation of the patient's utilization of the drug, which includes early and late refills or other evidence that the drug is not being utilized properly. It also uses the phrase prescription or drug order, so that rule covers inpatient and ambulatory care settings as well. The pharmacist is required to review patient medication profile whenever a medication is dispensed in an inpatient or outpatient setting, as we just mentioned. And reviewing the medication profile ensures the drug safety and efficacy, and as we just mentioned, only the pharmacist can do this process. Adherence to the medication and utilization of the therapy should be part of this review. So if the technician notices anything that flags them, a late refill, something the patient says, or a detail noted during the typing of the prescription, they should be sure to flag the pharmacist of this important information. The Supreme Court of Washington has concluded that a pharmacist has a duty to take corrective measures when confronted with a prescription containing an obvious or known error, such as an obviously lethal dose, inadequacies in the instructions, known contraindications, or incompatible prescriptions. The pharmacist is not required to contact the prescriber in every case where a potential problem is identified. WAC 246-875-040 only requires contacting the prescriber if needed. However, it is clear that the pharmacist must take corrective measures when problems are discovered. A couple of obvious possibilities include consulting with the patient to gain more information that helps them to resolve the problem. An example of this is a prescription is written for Tylenol with codeine 30 mg tablets with the direction to take 1 to 2 tablets every 4 to 6 hours as needed for infection, PRN infection. This suggests a possible error in the product that is specified, or at least inadequacies in the directions. However, the pharmacist notes that the patient has also a prescription for an antibiotic, which is also labeled for infection. She asks the patient what the physician told her the Tylenol with codeine was for, and the patient responds, "For the pain of my sinus infection." This clarifies the order, and the pharmacist may resolve the problems by augmenting the directions to read, "Take 1 to 2 tablets every 4 to 6 hours as needed for pain of sinus infection." Exercising his or her judgment is also a possibility, and subsequently informing the prescriber of the decision. For example, a prescription is received for a 3-year-old for 30 amoxicillin 250 mg tablets to be taken Q8 hours. The dose is appropriate for the child's weight, but the child cannot swallow capsules. The prescriber is not immediately available for consultation. The pharmacist discusses with the mother the choices of liquid or chewables which the child can ingest, and they agree upon the use of chewables. This is not technically allowed by the generic substitution rules, but it is arguably a form of secundum artem that effectively solves the problem. This will allow the resolution of the problem promptly and get the mother and the sick child on their way, and the pharmacist can then notify the prescriber of the decision, which will normally be acknowledged without any problems. Washington was the first state in the U.S. to require all pharmacists to provide patients consultation. The original rule, promulgated in 1973, specified that, quote, "with each new prescription dispensed after January 1st, 1974, the pharmacist, in addition to labeling the prescription in accordance with pre-existing requirements, must orally explain to the patient or the patient's agent the directions for use and any additional information in writing if necessary to assure the proper utilization of the medication or device prescribed. For those prescriptions delivered outside the confines of a pharmacy, the explanation shall be by telephone or in writing, provided that this shall not apply to those prescriptions for patients in hospitals or institutions where the medication is to be administered by a nurse or other individual licensed to administer medications, or to those prescriptions for patients who are to be discharged from a hospital or institution." End quote. This regulation, although it set a national precedent, was limited to requiring information on new prescriptions only. In addition, in its actual application, pharmacists tended to limit their counseling to fairly superficial issues. Also, the board has over the years been disappointed with the extent of compliance with which this requirement is being met by pharmacists. In 2001, the board promulgated a revised patient counseling regulation which sets forth in its purpose as educate the public in the use of drugs and devices dispensed upon a prescription. The pharmacist shall directly counsel the patient or the patient's agent on the use of drugs or devices. For prescriptions delivered outside the pharmacy, the pharmacist shall offer in writing to provide direct counseling and information about the drug, including the information on how to contact the pharmacist. For each patient, the pharmacist shall determine the amount of counseling that is reasonable and necessary under the circumstance to promote safe and effective administration of the medication, as well as to facilitate the appropriate therapeutic outcome for that patient from the prescription. This rule applies to all prescriptions except for when a medication is to be administered by a healthcare professional who is authorized to administer medications. Under the current law, it differs from the old law in several significant ways. First of all, it is not limited to new prescriptions only. It requires an offer to counsel, not just written information on drugs dispensed outside the pharmacy. It requires the pharmacist to evaluate what is needed to promote safe and effective use of the drugs and facilitate an appropriate therapeutic outcome, and to tailor the counseling to the specific patient. And lastly, it no longer specifically exempts hospital or institutional discharge medications from its requirements. These are very comprehensive laws and really should facilitate the patient's access to the pharmacist and appropriate drug information. The technician can help with this, however. Over 90 rules, the federal rules require that pharmacists make an offer to counsel for all Medicaid patients, and if the offer is accepted, over 90 sets forth the following significant items that the pharmacist should be prepared to discuss with patients, including the name and description of the medication, the dosage form, dose, route, and duration of therapy, special directions for preparation, administration, or use by the patient, common severe side effects, adverse effects, interactions, or contraindications that the patient can detect and deal with, self-monitoring techniques, storage and refill information, as well as what to do if a drug is missed. This summarizes the state rules and requirements on patient medication records, drug use reviews, and patient counseling. You see there are over requirements for the medication records. This Omnibus Budget Reconciliation Act of 1990, which mandates the offer of counsel to patients about prescriptions, as we just discussed on the previous slide. It also specifies the components of patient counseling. The requirements include the 7 elements that we just listed from the previous slide. HIPAA has been the center of recent national attention regarding the protection of patient privacy information. However, Washington has required confidentiality of patient records in pharmacy regulations at least since the inception of mandatory patient records, and the Washington legislature passed a Comprehensive Healthcare Information Act in 1994, prior to HIPAA. Other state rules affecting the privacy of medical records include the AIDS Omnibus Act of 1988 and various statutes and regulations regarding mental health. Federal laws also govern confidentiality in substance abuse treatment programs. The privacy rules of each state are important for practitioners to understand, since HIPAA does not preempt any state or federal privacy rules, which are more stringent than HIPAA requirements. Thus, in each state, what is actually required will be a combination of the federal and state rules. HIPAA was amended in 2009 by the HITECH Act, or HITECH Act, and important changes will be occurring between 2009 and 2017. The HIPAA privacy rule is encoded at 45 CFR 160 as well as 45 CFR 164. Its principal features include protected health information is that which relates to a health condition, both past, present, and future, and identifies the patient. Covered entities may use patient or protected health information for TPHCO, which includes treatment, payment, healthcare operations, which can include consent from the patient, is not required. HIPAA has been the center of recent national attention regarding the protection. We just mentioned that patient or protected health information can be used for treatment. Treatment consists of processing prescriptions and dispensing of drugs, maintaining and reviewing a patient's profile, consulting with prescribers relative to a patient's care, providing emergency information necessary for the patient's care, providing the patient or caregiver with information regarding the patient's information and consulting with them, or transferring refill information to or from other pharmacies. This is typically how treatment occurs in the pharmacy and are all consistent with the use of PHI for treatment. We mentioned that PHI can be used for payment. Typical pharmacy activities involving payment would include determining eligibility or coverage, pre-authorization of prescriptions and online prospective drug reviews, billing third-party payers, justifying charges, collecting payment from the patient or collecting past due charge accounts, providing certain information to consumer reporting agencies, transmitting credit card charges, and refunding charges or payments. Lastly, we mentioned that PHI can be used for healthcare operations. Typical pharmacy healthcare operation activities would include quality assurance within the pharmacy, quality assurance activities with external organizations, contacting providers or patients with information on treatment alternatives and related functions that do not serve or do not include treatment, medical reviews, legal services, auditing, and fraud or abuse detection, employee training and development, complying with regulatory agencies and complying with other provisions of HIPAA, as well as inventory control and planning. HIPAA requires that the patients be provided with a notice of privacy practices which advises patients that what you will use their protected health information for, which generally falls under that TPHCO category. It spells out what that means for your pharmacy, advises patients of their rights, advises patients that you do need written permission to release PHI for non-TPHCO purposes, identifies the pharmacy's privacy officer and how to contact that person, describes business associate relationships, describes applicable state laws and regulations, and describes how you will notify the patients of changes. Also, most pharmacies will take advantage of the option to notify the patient of changes to the Notice of Privacy Protection Act by posting them in the pharmacy. The NOPP may use a signature log for recording the acknowledgement of receipt. It should place an indication in the computer record that the notice was provided. The title of the notice must be printed exactly as stated in the regulation as, quote, "This notice describes of how medical information about you may be used and disclosed and how you can get access to this information," end quote. The pharmacy must post a notice announcing the availability of this information. It must provide a copy of the NOPP to any person who requests it. It must track changes to the NOPP, and because changes prompted by the HITECH Act, the pharmacies will need to amend their Notice of Privacy or their NOPPs in February of 2010, although this should have been done long before you get to the pharmacy. The patients are allowed to access their protected health records. They can request changes to the records to correct any errors or update it with new information. The pharmacy must also provide copies of the health records upon request. Federal law mandates that all of the information must be available within 30 days of request if the information is available on site. If the information is located off-site, the provider has 60 days to provide the records. The provider may charge a fee for copying or accessing the record. Patients can request changes to their record. The pharmacy does not have to agree to the change of the record, but must respond to the patient with the answer in a timely way. If a record is not changed, the patient may insert a statement into the record themselves. Washington state laws are more restrictive than federal laws for patient access to medical records. The pharmacy has to provide the patient a copy of their health information within 21 days of the request. The pharmacy also has to have an initial response to the patient request within 15 days. Also, there is a time limit to process the change request to the patient health record, which includes 10 days for the initial response to the patient's request, and the change must be addressed in 21 days. Again, more restrictive than the federal HIPAA limits. As technicians, you can help to protect patient health information as well as helping the patients, to understand their rights and all the rules and regulations. Oftentimes, a technician will be made the chief privacy and security officer within the pharmacy. This is not a role that a pharmacist has to fill. Also, technicians often are the first pharmacy staff member to greet a patient and give them forms, including the Notice of Privacy Act. Technicians also may need to convey patient information requests to the right person. And lastly, technicians have the same responsibility as pharmacists on privacy rules, so they will need to act accordingly. The patient may request that the provider provide a list of all the disclosures of PHI made during the 6 years prior to the request. The provider is not required to account for disclosures that are made directly to the patient, made to carry out TPHCO, made pursuant to an authorization granted by the patient, made to the persons involved in the patient's care, or made prior to the implementation of the HIPAA laws, which is April 14th of 2003. If the provider maintains a qualifying electronic health record as provided in the HITECH Act, then the patient may request a listing in electronic form of all the disclosures made during the prior 3 years. The exceptions above do not apply. The effective date will begin based on when the provider first adopts an EHR. If the EHR was adopted prior to January 2009, then the system must become capable of reporting all transactions by January 1st of 2014. An EHR system adopted after January 1st of 2009 must be capable of reporting all transactions from the date of adoption. It is not clear whether current retail pharmacy medication record systems constitute electronic health record systems under the HITECH Act. At any rate, current pharmacy systems would be subject to the 2014 start date. The provider may not charge for the first accounting provided to the patient within any 12-month period. A reasonable cost-based fee may be charged for additional requests within 12 months. Some disclosures made to law enforcement agencies or as a result of a court order may not be subject to the accounting. The pharmacist should consult legal counsel in these cases, since the rules are complex and involve both state and federal restrictions. Washington pharmacy law allows patient information to be released on certain cases without patient's consent. The pharmacy can release the health information to a person who is reasonably believed to be providing health care to the patient, to providers previously treating the patient if necessary for patient's care, unless patient has said not to disclose that information to them. Also, the Washington pharmacy law allows patient information to be released in certain cases without the consent of the patient. The pharmacy can release the health information to the following persons: to a person who is reasonably believed to be providing health care to the patient, to a provider previously treating the patient if necessary for the patient's care unless the patient has said not to disclose, to any person it is reasonably believed to be needed to avoid or minimize imminent danger to the health or safety of the patient or another individual. Oral if made to an immediate family member or other person with whom the patient is known to have a close relationship in accordance with good medical or professional practice, unless the patient has instructed the provider in writing not to make the disclosure, to a provider who is the successor in interest to the previous provider, and these releases are permitted based on the judgment of the healthcare provider. Technicians must consult with a pharmacist before releasing any patient information without the patient's consent, except for routine treatment, payment, or healthcare operations use. As we've seen as a theme previously, the consent requirements in Washington are more specific than federal rules, and they include the following. We will discuss the care of minors on the next slide. Patients with STDs or HIV must consent to care. Military personnel records, health records, cannot be released without the patient's consent due to a non-inclusion in the RCW 70.02.050 rules. And lastly, the pharmacist must report the abuse or neglect of a child or vulnerable adult. These are only rough guidelines. If pharmacy staff have questions about the care or require disclosure of care of a minor or other person, local public health offices may be able to offer guidance for appropriate care and consent. For minors in Washington to consent to medical treatment on their own, they must be emancipated minors who must be at least 16 years of age or have a court order. Minors who are married or a non-minor may consent as an adult. Minors who are married to a non-minor may consent as an adult. There are also allowances in Washington state law for providers to document that the minor is capable of making their own health decisions, called a mature minor. We will discuss this further on the next slide. Minors who are at least 14 years old may consent on their own for treatment for STDs. At any age, patients may consent to receive contraceptive services as well as pregnancy termination services. Minors must be at least 13 years old to give consent to inpatient or outpatient mental health treatment. Also, minors who need treatment for chemical dependency must be at least 13 years old to consent on their own. As alluded to on the last slide, the mature minor doctrine offers an option for a provider to decide to treat a minor without parental consent. The pharmacist can provide any healthcare service within their scope of practice, such as immunizations, to a minor, with the minor's consent, but without parental consent, as long as the minor is capable of understanding or appreciating the consequences of medical procedure. The healthcare provider should document their judgment to apply the mature minor doctrine based on the patient's age, maturity, experience, general conduct as an adult, intelligence, training, economic independence, and freedom from the control of the parents. The pharmacy or any other health care providers must get the minor's consent to release health information to the parent if the treatment is related to mental health, STDs, contraceptive, or substance abuse. Pharmacies cannot release the minor's mental health medications without consent. This is a good reminder to ask patients who are minors about releasing the information if the parent is requesting it. Aside from all these treatment conditions, the parent or guardian can request to see the profile as well as give consent on the release of the medications. If the parents are divorced, Disclosures can be made to either parent who asserts that they are authorized to give consent. These are rules regarding domestic partners. Domestic partners have the same rights as married spouses. Each domestic partner has visitation rights, are able to grant informed consent for a non-competent partner, has the same rights to disclose information, may share a room in a long-term care facility, can take time off for the care of the other partner, is able to get insurance benefits offered to spouses, disability service benefits, and workers' compensation benefits that would apply to a spouse may also apply to domestic partners. These laws have become somewhat more clear since the legalization of same-sex marriage laws in Washington state in the winter of 2012. With this law, though, it can help you to make a decision on how to disclose some health information to one partner on behalf of the other one. There are non-health care rights described in the referendum also that we will not go into in this review. This concludes this session, which covered patient information.